Good afternoon to everyone who is attending the first Yellow webinar after the summer recession. And I'm very happy, pleased, and moved to present Stefano. Stefano Bellentani has no need to be presented. But I mean, the human link between Stefano and myself goes back, since more than 40 years, 30 years. And I consider Stefano my brother. And together we shared a lot of different activities and scientific developments. The father of all the developments is the Dionysus study, which actually Stefano invented, looking at the runway of Linate Airport in a hot July afternoon. But I mean, since then, Stefano moved around the world, is becoming one of the most influential person in terms of epidemiology. No, it's true. Epidemiology and diagnosis and treatment of NASH and NAFLD, or MASH and MAFLD, as you like to call it. And today, Stefano agreed to talk about the NASH update in diagnosis and treatment. So please, Stefano, go ahead. Thank you very much for accepting our invitation. And you have the podium.
Thank you very much for the invitation. And I'm very proud to be the first of the new Yellow seminar, web seminar. I know all the group of Trieste very well since many years. And I also consider Claudio as a brother, a really good brother, even if during the last 2 or 3 years we didn't see each other by person, but only by video or by phone. And I hope that in the next month we can meet together again. Okay. So I can probably share my slides here. Let's see if I'm able to do. Yeah, condividere lo schermo. Here we are. Yeah. Did you see something? No.
Yes. We just see a blank. We don't see the first slide. You have to go to the first slide. Yeah, perfect. Maximize and we are done.
Okay. To maximize this one.
Yes, perfect.
Okay.
Thank
perfect.
you.
Okay. Well, these are my disclosure. Not so much. I am an independent gastroenterologist and hepatologist, now working in my own clinic, I would say, because it's an outpatient clinic where I'm doing everything from endoscopy to fibroscan here in Switzerland, in Locarno, together with other specialists now. And I will start with the prevalence of NAFLD and NASH. As you can see from this slide, modified from Iannussi, the mean prevalence of NAFLD is 25%, and it goes from 13% in non-developed country until 30% in South America. This number, 25%, was exactly the same number we found in the old, already very old Dionysus project, 25 years ago. So it's really old. But as you can see in this historic slides, we found in the population of Dionysus a prevalence of NAFLD that was exactly 25%, which was the highest prevalence of all the other chronic liver disease like ACV, ABV related and alcohol related chronic liver disease. The prevalence was measured in general population, and the estimated prevalence of NASH is reported in this slide that should be around 2 or 3% of the population, of the general population. And this percentage were already confirmed, I would say, all over the world. But we were the first, and I am proud to work in this group together with the Italian Liver Foundation. And we were the first to do this and to show this. In children, also the prevalence is increasing very much together with BMI and together with other metabolic disease like obesity or diabetes. Now, there are also some studies that show an economic burden of NAFLD and NASH with highest cost, especially in USA and also in Europe. The natural history of NAFLD started from a fatty liver, which is very common in the general population and also in my outpatients here in Switzerland. And it goes through an inflammation of a simple fatty liver. NAFLD became NASH. You know that now there is a lot of discussion around the world about the nomenclature and the classification of this disease, because it has been proposed a new name of NAFLD that now we could name MAFLD, that means metabolic associated fatty liver disease. And the same was for NASH. We can say that now a lot of scientific research call him MASH, that means metabolic associated steatohepatitis. This revision of the classification and nomenclature is not already standardized and is not already recognized, but the main scientific association like liver association like AASLD and EASL, but probably in the near future they will propose a real worldwide consensus conference. And NASH is going to go through cirrhosis and hepatocellular carcinoma a long time, I would say, longer than, for example, ACV, chronic liver disease. And as I told just now, NAFLD is now considered part of the metabolic syndrome, together with diabetes, insulin resistance, and all the states of pre-diabetes, hyperlipidemia, obesity, and hypertension. There is a large, wide spectrum of NAFLD and NASH. There is a primary NAF associated with the metabolic syndrome, but there is also secondary NAFLD associated with the use of some drug like steroids, amiodarone, tamoxifen, and so on. There are also metabolic and genetic alteration associated to NAFLD. And there is a big chapter associated to the nutritional state of each individuals and to the lifestyle. You know that now there is a very big discussion from a clinical point of view of lifestyle, and there is a branch of medicine that now is called lifestyle medicines, and I discovered that there is also an European Association of Lifestyle Medicine, whose president now is Dr. Stefania Ubaldi, an Italian one, that founded also a lifestyle Swiss association that I am going to reach in the next day, and so on. There are also other secondary type of NAFLD and NASH. As I told you, there are also genetic associated pattern of NAFLD and NASH that now we can measure because, for example, PNPLA3 polymorphism and TM6SF2 polymorphism are usually measured, at least here in Switzerland, when we found, for example, young people with unexplained alteration of liver enzyme and unexplained fatty liver. I have been asked to consult some very young boys here, and I'm following here in Switzerland at least 3 boys that have been addressed to me by pediatricians that are between 11 and 15 years old that have what we call the young NASH, and they are all genetically determined, and they all have at least one of these polymorphisms. The first one, which is the most common, PNPLA3 nothing NASH associated genetic disease. The 2 type of polymorphism are different. The one which is TM6SF2 is prevalently associated to a progression toward cardiovascular disease, while the other, the PNPL3, is associated with the progression towards cirrhosis and hepatocellular carcinoma. NAFLD and NASH are very broad disease, and as you can see here, the main causes of mortality are extrahepatic malignancy and not liver-related disease. The extrahepatic malignancy associated with the mortality of NAFLD people are breast and ovarian cancer in women and colorectal cancer in men, but also in women. Then 25% of all causes of mortality are due usually to ischemic heart disease, cardiovascular or other correlated disease, and only the 13% of all causes of mortality are usually liver-related. There is a complex physiopathology that link together the intestine, what we eat, the nutritional status here, the adipose tissue, the intestine, the cardiovascular system, and the liver. And everything is going obviously through the liver, which is the chemist laboratory of our body, as you know. And the time estimation for development of cirrhosis from NASH is very long, is around 28 or 30 years. And if we calculate from fatty liver, is around 57 years. So probably all these patients are dying before of cardiovascular disease or other extra hepatic disease before becoming cirrhotic or before having a hepatocellular carcinoma. NAFLD now is the commonest cause of hepatocellular carcinoma in Northeast UK, and the new data are coming out that probably is now the commonest cause of hepatocellular carcinoma worldwide, at least in the Western world. I will go through very few. I will show you only one slide about the update in diagnosis, because the diagnosis of NASH, the golden standard still for NASH, the gold standard for NASH, for diagnosis of NASH, is liver biopsy. For NAFLD and the development, the progression to NASH and cirrhosis, there are now new non-invasive predictor of advanced fibrosis, which are shown in these slides. The first one is APRI score, which is very simple, and is the difference between the value of AST to platelet ratio index. Then there is a FIB4, which is based on age, transaminases, and platelet count. Then there is NAFLD fibrosis score, which is more complex, and BARD. All these four scores, especially FIB4 and NAFLD fibrosis score, have been validated already in different types of population and are considered now the best score, non-invasive score, to make a diagnosis of progressive NASH. I will focus my speech today, especially to therapy, because it's amazing which kind of developing there is in therapy of NASH. A lot of study are coming out, and a lot of new trials, clinical trials are coming out every week, I would say, not only every month now. And as you can see in this slide, I repeat to you that NASH is a part of a multi-system disorder. So we can treat NASH also by treating cardiovascular disease, pancreatic disease, kidney disease, and obviously hypertension. And there are a lot of already on the market drugs that we can use for all these diseases. This is an old slide, 5 years old slide, so it's not so old, but is already old, where we can see that the real management of NAFLD was, until 5 years ago, lifestyle modification that is able to take care and to treat all the different stages of NAFLD. NAFLD, NASH, and NASH-related cirrhosis. Statin or cardioaspirin, if indicated, so if there is an association with cardiovascular disease, are also able to prevent the progression of this disease. And there is also a need to try to follow up these patients, especially the patients that we know are progressive toward cardiovascular disease, cirrhosis, hepatocellular carcinoma, or other extrahepatic disease, which are few, obviously, in respect to the high prevalence that I show you of NAFLD. The incidence rate of liver-related mortality in NAFLD according to the stage of fibrosis is illustrated here in a meta-analysis of this study that came out during the last not more than 8 or 10 years. And the incidence rate of liver-related mortality is increased. All the study, as you can see here, show by this meta-analysis that they are increasing according to the fibrosis stage. So the fibrosis stage is the clue to understand how this disease is progressive. However, non-invasive method to study fibrosis stage validated all over the world are few, and I would say that now the use of FibroScan that in the new machine give also a cap, which is a number that indicates the amount of fat inside of your liver, is going to be the gold standard for a clinician. So I really don't do anymore any liver biopsy since at least 3 years of my practice now. I also do almost always FibroScan. This is an original article on short-term multidisciplinary non-pharmacology intervention in patients with non-alcoholic fatty liver disease that we published in 2013, so almost 10 years ago. And we were the first to show that after 3 months of multidisciplinary intervention, that means intervention on lifestyle medicine, are able to reduce the fatty liver index and also some significantly, obviously, decrease, and also some liver enzyme like ALT, and also ultrasound fatty liver as measured by Hamaguchi score, which is a specific score of ultrasounds and the Doppler power index. So these were the first study that show that lifestyle intervention, that means a complex of not only diet, but also physical activity and psychological approach to the patients is able, also short term, 3 months, not more, is able to treat NAFLD and to stop the progression to NASH. Lifestyle modification has been, after our study, demonstrated to be effective in treating the NAFLD and NASH also by other authors, as you can see here. And the pharmacological treatment of NASH that we knew 5 years ago were only these two, vitamin E and pioglitazone. Is impressive that in the year 2022, only this year, Food and Drug Administration and also European EMA approved medication for NASH, like, for example, semaglutide, Ozempic, already approved for diabetes, and other agents like tirzepatide are among the agents that we have to watch very close because probably they will come to the market. That is just to let you know that only in this year we have some drug available to treat patients with NASH. But I suppose that in the next year, as you can see from these slides, which really is a confused life, is very difficult to illustrate these slides, but is a landscape that I want to show you in one picture, just to let you know how many clinical programs and how many clinical trials are going on nowadays, just after only 5 years from when we have only 2 drugs available, vitamin E and pioglitazone. All the drugs that are available are on study now are illustrated in these pictures, and they act in different parts of the metabolism. And as you can see also in the next pictures, in the next table that I show you, and I suggest you to read this review if you want to just learn something more about pharmacotherapy, which is very well done, and it has been published only in January of this year in Biomedicine. The major pharmacological targets in NAFLD NASH today belong to different families. THR beta agonist, PPR alpha or beta family, lipogenesis inhibitors, and are all these one, bile acid metabolism modulator, and there are all these one, fibrogenesis inhibitors, and are all these one, and so on. Glucose metabolism modulator, and are these one, and other agents, also probiotics, for example. There are a lot of study ongoing on probiotics to try to treat NAFLD and NASH. An overview of the current drug development pipeline for NAFLD and NASH are illustrated in these pictures. And this is an old picture, November 2021, but also if it's only 6 months old, you can see that there are at least 140 clinical trials in phase that we don't know which is it, not applicable. There are almost 100 clinical trials ongoing on phase 2, and on phase 2A, other 40, on phase 3, 30 study, on phase 2B, and so on. So you see, there are a lot of clinical trials, more than 400. I would think that now, I think that now we are around 500 clinical trials that are ongoing all over the world. And you can imagine the market interest and the big company, the big pharmaceutical company, which kind of interest that can have in this disease. The mechanism and the effect of some of these drugs are already known. For example, there are some drugs in the market that cause resolution of NASH, and some other that can give us also an initial regression of fibrosis. The most interesting one are the GLP-1 agonist, liraglutide and semaglutide, which have been already approved both for diabetes and also for NASH, and that are able to stop NASH or to treat NASH, and obeticholic acid, selonsertib, and well, it's difficult to pronounce, Cenicriviroc, which these last two are not already in the market. Obeticholic acid, which is an FXR agonist, is already in the market. This is a beautiful, very nice illustrated slides that give you an idea which are the drug that are very close to the market. As you can see here, Ocaliva, obeticholic acid, is already on the market, but now also these two, semaglutide and liraglutide, semaglutide and liraglutide, GLP-1 inhibitors, are already in the market, and the other one are online, but they are becoming the market. So within few years, we will have a lot of choice of drugs to treat the NASH. This is the mechanism how liraglutide and semaglutide can act, and it's very interesting because they are very interesting drug because they increase insulin sensitivity, and they are also drugs that are able to treat patients with obesity. In Switzerland, we are allowed to prescribe, covered by the insurance, liraglutide and semaglutide for obese patients. That means for all patients that have a BMI greater than 30. And this means that these drugs are also able to act in different parts of the body, and also in the sense of satiety, because they induce loss of weight. This is the milestone trials published on the New England Journal of Medicine in November 2020 that demonstrate that semaglutide is able to treat non-alcoholic steatohepatitis. Is a drug that you can use by injection and by injection under the skin, and you can use it 5 days a week, in the beginning with a low dose, and then you can increase the dose to reach a plateau. And you can use it for more, not for more, at least here in Switzerland, not for more than 3 months consecutively. And then you can also repeat another cycle after 3 months of pause, because in 3 months you reach at least a 15% of reduction in weight, and also in reduction of liver enzymes in the blood. So it's a drug that is working very well, and it has no collateral effect, only one, which is quite important for some patients, which is a terrible nausea and sometimes also vomit. These are late breaker session of EASL this year in April in London. These abstracts have been presented as late breaker session, and the results show that there was also an improvement in liver fibrosis in patients which have NASH cirrhosis. And this is very interesting because it means that these drugs are acting probably also on fibrosis. And uh, Semaglutide in particularly improved also cardiometabolic parameters like triglycerides, VLDL cholesterol, and improved also non-invasive marker of liver injury associated with fibrosis progression. Uh, Obviously, these were only 80 patients compared with the 80 placebo patients, but the results suggest us to do larger trials to demonstrate this. And then I just take you some more minutes to speak about bile acid and NAFLD, because bile acid are acting through this farnesoid X receptor, and we have some drug like obeticholic acid now, who is just acting on farnesoid receptor. But the result of these trials seems not to be so interesting like the other result that I showed you before, because the improvement was not more than 20%, both in improving liver enzyme and improving a non-invasive marker of fibrosis and also fibrosis, but only of one stage by liver biopsy. Uh, they are safe drug, they are on the market, they have been put on the market before to treat CBP and cholangitis, chronic cholangitis in general, but now they are on the market also with the indication of NASH. And they have a big and important collateral effect, which is pruritus. And pruritus for a patient is very difficult. And all the patients that drop out from clinical trials and also from real life trials are patients that are getting pruritus, which is present almost in 30% of the patients in real life. So this is an obstacle to treat patients with obeticholic acid. Then there are new drugs like GS9674, which is quite promising. The PPR anti-receptor drugs are no more studied because, for example, elafibranor was very close to go to the market, but the last trials show, the golden study, show that there was no significant improvement both in liver biopsy parameter of inflammation and liver biopsy parameter of fibrosis. So this pipeline was closed. There are some other new pipeline drugs that for me are close to be to arrive on the market. For example, the ASK1 inhibitors, and also this one, which is selonsertib, which give very good results. And also Chenicriviroc, the name that for me is unpronounceable. Okay, there are also some pegylated drugs that have been shown to improve both inflammation and fibrosis. And there are also few studies now, very few, that are studying combination of different drugs. For example, combination of AES-K1 and acetyl-CoA carboxylase inhibitor, but these are by now only in animal models. Um, Other things, well, this again is an late breaker session of years this year, and in a group of well-compensated NASH cirrhotic cohort that have been treated with resmetirom, a thyroid hormone receptor beta agonist, for 52 weeks, or so for almost 1 year. They show an improvement of not only inflammation and fibrosis in the liver, but also a reduction in the markers of cardiovascular risk, and they have been well tolerated. So as you can see, there are a lot of new drugs facing in the common practice, clinical practice, and probably the following year will be very stimulating for the clinicians because we finally have a lot of instruments to try to treat all the patients with NASH. NASH management will be a paradigm in the next decade. And as you can see here, after initial diagnosis, you have to reassess probably all the organs, following up every year probably, and you will have a target therapy for active NASH, for fibrosis, and you can improve health, but not only health, probably also the quality of life and the mortality. Thank you very much for your attention. Finish.
Thank you very much, Stefano. You can remove the slides and then we can have the full screen. I think that your presentation has been very, very inspiring. And I open this to discussion. Is anyone willing to have a question for Stefano?
Yes, I would like to make a comment for Stefano.
Yeah.
So thank you for your presentation. And I would like to ask your personal opinion, because we know that we have some trials that are going on with promising results. But in your opinion, which would be the best moment to treat the patients, considering the progressive nature of NAFLD and the available options that we have for diagnosing the stages of the disease? Which would be for you the best moment to say, okay, I will put these patients under treatment?
The best moment?
Yes.
Well, you know, sometimes it's not so easy to understand which is the exact moment to put the patients on treatment. I would say that two things. So the first thing is that if you have a patient with which is not only obese but overweight, with alteration of liver enzyme, and with the fatty liver at ultrasound, for example, and maybe also stage of low stage of fibrosis at fibroscan, for example, F1, F2. Well, that patient has to go to a program of lifestyle intervention. This for sure. I try, I also here, I have a collaboration with physiotherapists, dietitians, and also behavior psychologists. And so I can, you know, address my patients in this multidisciplinary treatment, even if the patient is in the initial stage. Then when I will try to use drugs, well, I will try to use drugs in at least in two moments. When I understand that the NASH is progressive towards cirrhosis, so I am following up the patients with ultrasounds and with blood tests, and I have availability of FibroScan, so also with FibroScan every 2 years, for example. And if I understand the patient is progressive towards fibrosis, different stage of fibrosis and cirrhosis, well, I will start a drug. Probably I will start either with obeticholic acid or with semaglutide. And this is one case. The other cases is that when I failed, when the patient failed to follow the multidisciplinary treatment, non-drug treatment, obviously. So when is no more able to lose weight, for example, if he is obese or diabetic. Almost all diabetic not only have NAFLD and NASH, but they are also obese, the majority of them. Well, when they failed, I can use semaglutide because it's, or liraglutide. It depends if they are diabetic or not diabetic. If they are diabetic, I use semaglutide. If they are not, I use liraglutide because they are very effective drug in just lowering, you know, weight. So I use them.
Okay, thank you very much.
Thank you very much, Stefano. Can you remove, I mean, can we go to the screen where we can see you, and then
I'm not on the screen, I'm sorry.
No, this is something else. Okay, there's any other question?
I have a question, or maybe a thought. It's okay.
Go ahead, Terry.
It was a really nice talk. It was really educational. You got me up to speed. I really appreciate your very well organized and delivered speech this morning, or presentation. So a few months ago, we published in Hepatology where we showed different stages of liver fibrosis, and we measured the kinase activity. So it wasn't just a kinome, it was actually a measure of kinase activity. And you know, in the fatty liver with fructose, high-fat diet fed mice, not surprisingly, they had a fatty liver with insulin resistance. But as we found that with different stages of liver fibrosis, the insulin sensitivity changed. So for instance, we had 10 humans healthy and 10 cirrhotic controls that we also measured. And these are stage 4 fibrosis, so, you know, end stage fibrosis. And they had significantly higher insulin receptor activity in the human livers with cirrhosis. And we found that it was specifically in the stellate cells, you know, the cells that cause the fibrosis, not the hepatocytes. So it was kind of a new finding, and it was kind of, well, very surprising for one. Do you think that a lot of these insulin sensitizers could be problematic for the end stage fibrosis?
Well, I don't know. I don't know. I don't really know. It's quite interesting, your question, but I don't know if you, Claudio, have some answer.
No, no. I mean, I think this is very important information and observation. I mean, first of all, we need to be careful to translate what we see in an animal model to the human patients. But I think that in general, if you can,
Well, this was in humans.
it was in humans. Okay,
It was humans. We did both, animals and humans.
I know you. I mean, the paper you published in Hepatology, if I remember correctly. Is that correct?
Yeah, right. You're familiar with it, yeah.
Exactly. I think that this may be one way to go, but the real question is, and this goes back to the question of Natalia, when we start the treatment and at which stage we can revert the process. Because, and that is my question for Stefano.
Yeah.
I mean, I think that the data you presented was really appreciated because it was a very comprehensive and critical approach of what we have on the market. And let me tell you frankly that we have too much in the market because the stake is very high because the market is huge. So anyone having a compound will try to sell this compound is miracle, which is not. But anyway, if we go and we concentrate on the drugs or the drug, which seems to us now the most impressive, as you mentioned, semaglutide. The question is, I mean, how much is this related to the drug in terms of the liver, and how much is the effect related to the reduction of weight? Because this is the crucial issue. Because as you wrote, very ahead of the time, I think was 2021, that is fatty liver as a liver disease or a heart disease? You wrote in Journal of Hepatology.
Yeah.
I think that what we're dealing here is something which is much more related to metabolic than liver per se. So liver is one of the players. So if I treat what is behind the whole thing, which is that diabetes, with hypertension, with obesity, particularly obesity, then the rest is coming along. So I wonder how much we need to pay attention and how much was paid attention in the study you presented on the role of weight loss, because I think that this is most probably crucial.
I agree. It's actually the point I was agreeing with you. I agree with you 100%. So one of the aspects we looked at we're thinking about was maybe the insulin sensitizers are stopping the adipose from lipolysis.
Exactly.
And then that's why I was bringing it up that so the humans that had cirrhosis, they didn't have large body weights, so they didn't have the obesity factor, but their hepatocytes are dead because they're end-stage cirrhosis.
But then
once they have cirrhosis, I agree completely. I agree completely. But I mean, it's true. We could treat everyone just with lifestyle intervention. We could really treat everyone just trying to change lifestyle of our patients. But this is the most difficult things, because each patient can follow you for a few months, but then it drops out. And we all know that after 1 year, if you have not a support of a drug, probably they fail, So I agree with you. But especially for the new GLP-1 inhibitors, I'm speaking about semaglutide and liraglutide, I think they really help because they really give a lot of nausea, and the patients, while is following a diet and an increase of physical activity, does not like any more food, and this helps very much, I think, because these drugs are quite complex. Probably we don't know where they act, but they also act on the brain, I'm sure, because they take out the sense of come si dice fame, non mi ricordo più.
The hunger, I mean,
Yeah.
they remove the need for food.
Yeah, yeah. And so I think they help. But obviously, I agree with you. We can just treat all the patients only by convincing them to change lifestyle. But this is the most difficult things for a clinician, you know.
But if you allow me to make one comment, Stefano and Prof, there's a paper saying that the effect of bariatric surgery addressing like the main driven force is the weight loss. And it depends on the basal status of the liver of the patients. If they had an initial fibrosis or a progressive fibrosis, the effects could be a regression or nothing happens, even if they lost a lot of weight. So it depends of when you make an intervention in the fate of the patients. I don't know. It depends. If you are able to induce some behavioral changes, and if the liver is not progressing towards fibrosis, then perhaps you can succeed in any attempt to avoid the progression.
I agree with you, Nata, but I'm asking you a very difficult question. Are you able, because I am not able,
No.
are you able to establish when, at which point the disease is still reversible?
No way.
We don't know. That
No
is the point, you know?
No way. So it's very difficult.
Yeah, but there's something else which is much important in my opinion. I think that what we need to do is try to concentrate to understand a magic bullet or some biomarkers or something mystical science. I really don't know every day. Why, if you take now, I mean, let's say 100 persons with fatty liver, diabetes, and obesity, and you follow up them for 30 years, only 30 develop cirrhosis.
Yeah.
And I mean, the other 70 die for stroke or for cardiovascular disease. I think that what we need to do is try to understand why some of them follow one way, one path, and some of others are follow other path. And this is what we call personalized medicine. We're still very far from this, but I think this is the direction. And I think that using drugs may help understanding the basic, most probably genetic attitude. Because I mean, if you go, for instance, in Asia, I mean, few of them are obese. If you go to America, on Europe or South America, boy, I mean, a lot of them are obese. And even more important, in my opinion,
especially in Kentucky.
Right. It's the best way to get.
Yeah.
KFC is horrible. It's beautiful, but it's hard for your liver. But what I'm saying that even more important is not, I mean, when you deal with children, because adolescents are much more prone to develop a more serious disease.
Sure.
And it is expected that now the overweight child is actually exposed. I think they calculated 10 times higher risk to get liver disease, serious liver disease, and liver transplantation at the age of 40. So I think that we have really a world to explore. And I think that by combining basic studies with animal studies, with all the caveats of the animal studies, but also all the advantages, and serious human trials, we most probably can get up a sort in 10 years an answer. I think that's good.
Yeah, I agree.
Can you remove, I mean, can we see your face rather than a beautiful?
I am not able, I'm sorry.
You have to switch to switch the share of your slide, the share of your slides.
Well, okay, let's see. Okay.
Okay, at any rate, is there any other question?
I'm not able.
Okay, there is any other question? Well, if not, thank you very much, Stefano. It's been a very inspiring,
You're welcome.
very inspiring seminar. And we really, I mean, I personally enjoyed and I learned a lot. and I'm pretty sure that all the attendees already got their mind to understand what we have to do to improve our lifestyles and reduce the risk of getting fat and getting a fat liver. And I think that we're very sure to understand that there's a lot of good people working on that. Thank you very much, Stefano.
Thank you, Claudio. Bye. Bye.
Ciao, ciao.
Thank you. Bye.
Ciao.
Bye, bye, bye.